Welcome to today's edition of Ask the Doctor. Today's topic is hypertension. My name is Gurjeet Kalkat. I'm the Chief Medical Officer, and I'm joined by
Hi, I'm Dr. Lisa Thomsen, family medicine in your community.
Dr. Thomsen is a family medicine doctor who has been in practice for more than 30 years. Her office is in Glendora, but she sees patients from surrounding communities of Glendora, Covina, San Dimas, Laverne, and even Duarte. We are very, very happy to have her. It's our honor to have her. She has served this community very well, and she's a very good thought leader on many health topics. Hypertension affects a lot of individuals. Actually, it's one of the most common causes of a visit to a family medicine doctor. Unfortunately, many patients do not know that they have high blood pressure because it's silent until it's very late. And even if when they have it, more than 50%, the blood pressure is not well controlled. So what's the importance of controlling high blood pressure if one has it? It's a major risk factor for many things. For example, high blood pressure can cause a stroke, bleeding, and another kind of stroke. It can cause kidney disease, kidney failure. It can cause heart failure or a heart attack. So let's start talking about high blood pressure or hypertension. Dr. Thomsen, let's start with the definition of hypertension.
Sure. So, according to the American Heart Association, hypertension, or reason to initiate to treatment, is a systolic blood pressure, which is the upper number of two numbers of 130 or greater, and or the diastolic blood pressure, which is the lower number of 80 and greater.
And then let's talk about how to measure blood pressure. In the past, we used to use a stethoscope and we used to use that to measure blood pressure, but we have realized that the electronic way of measuring blood pressure is much more accurate. So this can be done in an office setting, but even at home, most of the devices available in America are well standardized that they work really well. We recommend a device which will measure blood pressure above your elbow, that's called the brachial area, and you should have the right size cuff. Inappropriate size cuff will give you the wrong readings. Then in the beginning, you must check your blood pressure in both arms. Typically, the blood pressure is within 15 millimeters of each other in both arms. If it's more than that, there is a problem with circulation to one of the arms. And whichever is higher, you measure in that arm. Dr. Thomsen, let's talk about the risk factors for hypertension. What are the risk factors for hypertension?
Okay, so there's two types of hypertension. You have primary hypertension, which is the majority of all hypertension, and then you have secondary. So when you talk about primary hypertension, you're thinking about factors that you may or may not have impact on. So very commonly, age is a factor that contributes to hypertension. So as we all age, we increase our risk of having hypertension. And especially over the age of 60, 75% of the adults can have hypertension. Another major factor that we actually have some impact on is obesity. And we do determine obesity by a calculation of weight over height. It's a BMI process. So by definition, you may hear these numbers passed around. If you have a body mass index or a BMI greater than or equal to 25, someone would call you overweight. But you're considered obese when you meet a BMI number of 30 or greater. And so being overweight or being obese is definitely a risk factor that contributes to hypertension. And then there's some things you can't do anything about. There's family history. And so if you have a parent, one or two, that have hypertension over your lifetime, there's a twofold increase that you may develop high blood pressure. And then there's even indicators by genetic loci. So if you have certain loci in your gene pool, you also increase that risk of hypertension. And other risk factors also can include dietary, so excessive sodium intake. And by definition, I think the current definition is more than 3 grams of sodium per day. So we really would like to push that down. And just think of it like this. 1 teaspoon of table salt, that's 2,400 milligrams right there in a single day. So we're really trying to get people to drop that sodium intake. And you can impact it by limiting your alcohol intake. And in the United States, we are referring to a full-grown male, 2 standard drinks a day is acceptable, not higher. And a woman would be 1 standard drink a day. Other factors that are involved include race and ethnicity.
Yeah, race. As we know that blacks and Hispanics, especially blacks, have more hypertension incidence. When they get it early in life, and when they do get it, it's more severe than their other race cohorts.
Absolutely, have more target organ damage at that time. Definitely smoking increases our risk of having hypertensions for all you out there. And I don't sanction vaping either, so that's just as bad. So smoking it in the form of just inhalation of the nicotine in whatever form it is lends to it. And when you agree, Dr. Kalkat, patching, if you can also get rid of nicotine patches, you want that out of your system as well,
Absolutely.
Even though you're not inhaling it. And that also really reduces your cancer risk, and that's another topic. But physical activity, all of us can do a little bit of something, even me. And so those of us who are completely inactive, even if we can move our bodies around 6 minutes per hour, 6 to 8 hours a day, that would be making some impact on trying to lower your blood pressure. Those of us who are already somewhat active, you're really looking at about 30 minutes of aerobic activity 5 times a week, and then you can divide that up into moderate or vigorous activity.
So primary hypertension, as you mentioned, is the dominant cause, which affects about 90% or more. Then you have a few patients in your practice who will have secondary causes. And so let's go a little bit through the secondary causes of hypertension.
Absolutely. And the secondary causes, the big 3, we're really looking at sleep apnea. And now it is much easier to diagnose it and much easier to get insurance authorization, because that's a part of the challenge, just being a clinician and being a patient, is having the opportunity to have the diagnosis and have your clinician think of it. And then another part of the top 3 is renal vascular disease. And younger folks tend to have a condition more related to fibromuscular conditions of the arterial artery, and older folks can get what a lot of us already know, atherosclerosis. So clogging of that artery from cholesterol can increase their risk as well. And those are all diagnosable and can be treatable.
In addition to the causes she's mentioned, medical causes, there are some secondary causes which can be managed very easily. For example, if somebody is taking drugs like Advil for arthritis, that can raise your blood pressure by about 10 millimeters. Birth control pills, which have a higher amount of estrogens, can raise the blood pressure. Some of the antidepressants and antipsychotics can raise blood pressure. And worst of all is illicit drug use. Amphetamines, cocaine really raise the blood pressure to the point that it can cause a stroke or a heart attack. So Dr. Thomsen mentioned inadequate sleep. One of the most common causes of poor quality of sleep is sleep apnea. Apnea means cessation or stoppage of breathing. So there are individuals who, for many reasons, whether it is increased weight or anatomical problems up here, will stop breathing. And when that happens, there is less oxygen going to the body, and that raises the blood pressure, and that's the cause of high blood pressure.
And in primary care, we also have to pay attention to stimulants, right? Because we're seeing ADD and ADHD, and people who constantly are concerned about poor concentration, poor performance, but they certainly do elevate blood pressure, and you really have to monitor that population.
So we've gone through the diagnosis, the risk factors. Now, once you are diagnosed with blood pressure being elevated, so what do we do next? So we come to treatment. So there are non-pharmacological ways of treating blood pressure and pharmacological ways of treating blood pressure. So let's go through that. So let's go through the non-pharmacological treatment.
Okay, so when you think of non-pharmacological, this is where I love to engage you guys out there because you can take charge. I'm going to empower you to take charge of your blood pressure. So, of course, the healthy heart diet, very popularized years ago, was DASH, dietary approach to stopping hypertension. And really it went into eating certain foods for a certain amount. You didn't have to go and join a dietary program or anything like that. You go to the grocery store and write your list. And so it went into how many servings of whole grains, really pushing fresh fruits and fresh vegetables over canned and processed, really working on low fat dairy products, get away from, salty food products, those that are hidden salts in our breads, in pre-made packagings. And also what you're trying to do as well, you can impact reducing, again, as we said earlier, reducing alcohol intake. And I thought that was interesting because with the Mediterranean diet, there's a little bit juxtaposition of using your mono and saturated fats more into olive oils, and they had a slightly more moderation of alcohol use. But other interventions that were important with dietary is some will say increasing potassium supplementation. So you could eat your way by lowering your sodium, by excreting sodium and increasing your potassium. So you want to consume potassium-rich foods. And just examples of those could be your favorite beets, but there's other favorites out there like spinach and chard, kale, oranges. So you could have different ways of lowering your sodium by decreasing intake, and as well as eating more potassium, excreting your sodium.
Yeah, absolutely.
Right?
So just a few words about potassium. Clearly, some patients' blood pressure goes down when they increase the potassium intake, but one has to be careful if you are diagnosed with a kidney disease that you do not want to have excessive potassium because the potassium level tends to go up. So follow your doctor's instructions on potassium intake.
Absolutely. And potassium's interesting because if you're on certain medicines like diuretics, you'll lose potassium. So then your physician may actually prescribe it or ask you to continue to increase potassium intake. So there are quite a few hurdles and gauntlets you have to navigate. And that's why I always like my patients to feel we're really a team approach. Communication and what you're really doing out there helps me help you. And then other modifications you can really take charge of. And I really want you to do something like moving that body around. So physical activity. And I had one patient, she would really just get on her stress treadmill test, and she would go on her treadmill for 10 minutes a day, and we'd jump up and down. Hooray, you did it. So you did something. So set yourself up for small goals and make it successful, because that's how you start. And then when you're an expert, vigorous exerciser and you're doing 75 minutes per day of intense activity, you can also do that. And I have people like to do those with bad joints out there. Think about water walking. You're a little bit buoyant, but you're burning calories and you're getting aerobic exercise. So take advantage of things like that. And there's the unicycle for your arms. If you have issues with your legs, you don't necessarily have to jump onto a stationary bike. And then I have that group of population that work nights. So they're trying to sleep during the day. Absolutely impacts sleep efficiency, sleep quality. So we need to get good quality, efficient sleep. The number is you want more than 7 but less than 8 hours of sleep. If you get more than 8 and less than 7, that tends to lean or predispose you for hypertension as well. And then de-stress yourself. If you can find different ways to meditate, you can just even a few minutes of, but even that will help bring your blood pressure down.
Absolutely. Yeah, if one loses about 10 pounds of weight, it can decrease your blood pressure by 5 to 10 millimeters. Similarly, exercise about the same. If you exercise about 45 minutes, your blood pressure can go down by about 10 millimeters. So these interventions, these measures will help you take care of mild hypertension. But when it comes to more than mild hypertension, you've done all what you could, you've dropped your salt intake, you exercise, you stop smoking, stopped alcohol if possible, and the blood pressure is still high, and then you have to go to the drug therapy or pharmacological therapy. So a few words about pharmacological therapy, Dr. Thomsen. Go ahead.
So the recommendations are probably 4 major classes, and they're very reasonable. Always the thiazides, which are like a baby water pill. Some of you may have heard of the more harsher ones. And then we have the class of medication, the calcium channel blockers, but we're specifically focusing in on the group that are dihydropyridines. And then, of course, the next 2 groups are more related to the renal system or kidney system, which are the angiotensin converting enzymes and also the angiotensin receptor blocker agents. And knowing those classes, they do bring about their own side effects. So when you're using thiazides, we do have to worry about watching your potassium all the time because they tend to drop. Some people can also have allergic reaction to thiazides as getting rashes or even sun photosensitivity. So one of my patients on a thiazide loves to play tennis. So we try to pick a time of day where they're not getting as much sun exposure to trigger that photoreactivity. And then with the dihydropyridines, that calcium channel blocker group, if you push it high enough, a lot of my patients will get swelling in their ankles and feet. And my seniors come in with their favorite face, Dr. Thomsen, you gave me cankles. So they're swollen ankles, swollen feet, and then we have to dial down or alter their dose on that. ACE inhibitors, I find quite a few of them get coughs, and they may not always have a cough. They'll come in going, I'm clearing my throat. And now everyone's asking why I clear my throat so much. So I quickly look down on their list. Oops, it's their medication I chose for their blood pressure. And ARBs, generally, the only real issue I've had with some of the ARBs, sometimes shortness of breath. Have you seen that?
It's actually very uncommon. So what she's referring to is the ARBs, angiotensin receptor blockers. They cause swelling in the upper airway, and that can cause swelling of your tongue and even the uvula. So, but fortunately, it's a rare side effect. And if we mentioned that with the diuretics or the water pills, some make you lose potassium. There are some who actually can make you retain potassium. But common side effects are, cramping. Somebody with mild to moderate high blood pressure taking a diuretic cramps in the middle of the night. The answer is low potassium or even low magnesium. So that will be checked by a physician like her. The other drugs she mentioned, the swelling caused by so-called dihydropyridines, the most common drug is called amlodipine. The swelling is not related to fluid intake in the sense it's not fluid swelling, so it cannot be taken away by a diuretic. The drug has to be changed or modified in dose. So I have some questions from the public here. What is white coat hypertension?
Oh, I certainly have a lot of that. And my patients go, I love you, Dr. Thomsen, but don't wear the white coat because my blood pressure will be high. So in the office, as we're measuring our patients, we try a couple of different tactics, but it's elevated blood pressure in the office. And then when they go home, they have normal blood pressure. And it's kind of interesting because, as Dr. Kalkat alluded earlier, the automated and digital devices that we have really been a godsend in many ways, because once you teach and vet out the technique, teach your patient the proper technique, and vet out their abilities to reproduce that at home, you can really determine on that exact same device, because of memory, what that blood pressure is at home, and that patient brings that exact same device in the office, and you can actually see the elevation with me sitting in front of them. And so we also have the other strategy when we're concerned, we leave our patient in the room with the automated device. So we sit them properly in the seat, feet has to be touching the ground, we size up their arm with the cuff, and we show them, hey, just sit here and relax, and you push the button when I leave the room. And we'll have them do it a couple of times. Because of memory, we can see that. So white coat hypertension, it's not something we has a serious pathological outcome with it, but it is important to make sure, are we diagnosing the right hypertension, because that can be mixed up with masked hypertension.
Absolutely.
And masked hypertension actually does carry a twofold increase in cardiovascular disease and all-cause mortality. And masked hypertension is the exact opposite in definition. So these patients have actually very nice blood pressures in the office, but outside of the office, at home, or in some other setting, non-medical, they actually have high blood pressure. And again, we take advantage of those digital devices. The most popular, or the most well-known, or gold standard, is the ambulatory blood pressure monitoring. And that is also hurdles and hoops because we have to apply for insurance approval. We're only allowed once a year, but you do get 24-hour monitoring, which is wonderful, even while the patient's asleep. So that's ideal.
Yeah, in certain situations, we don't do it in majority of the patients. We do it in very selected patients to really see what their average blood pressure is during the 24 hours it monitors. You wear the machine all the time. And in those individuals, the cutoffs are a little bit lower. You know, if somebody's average blood pressure is over 125, the upper one, and over 75, the lower one, they are called, they're labeled as a hypertensive individual. Then on the white coat, it's also important that if somebody is treated based on their numbers in the doctor's office, and when they go home, they're relaxed and they are placed on a medication, they'll feel dizzy or they pass out. So it's very important to make sure that it's not related to a patient facing a doctor and blood pressure going up. But those individuals, in general, are sensitive in the sense under stress, their blood pressure tends to go up, whether in the physician's office or in other stressful conditions. So I think you have to do some lifestyle changes in those patients that, okay, don't be scared of situations, your blood pressure will stay low. Next one is, what is resistant hypertension? A patient said that my doctor said I have resistant hypertension. How do you define resistant hypertension?
So resistant hypertension, we're already talking about, we've started medication on you. And it's multiple medications, usually 3 or more medications, and your blood pressure still does not reach goal. And at that point, we do call it resistant hypertension. And then we are looking for secondary causes of resistant hypertension at that point, because now we're very suspicious that there is another reason why your blood pressure is remaining unresponsive to our medications.
And the other question is, can hypertension be cured?
Well, mild hypertension may have an opportunity to be cured because a majority of our population in the United States, we all are slightly overweight and maybe even borderline obese. And so when we drop that poundage, it's amazing how much blood pressure drops. And I have to add that even the stress and nowadays in people's lives. I had a patient who was on 4 medicines to control his blood pressure, had a 2.5-hour commute every day, got up at 3 o'clock in the morning to make it and came home around 8 o'clock at night. As soon as he retired, I had to eliminate 3 medications. My patient bottomed out. So the stress of his work and his commute really impacted his hypertension.
Absolutely. Yeah, there are some other scenarios in the sense, one is obesity. You know, you lose weight, you lose 15, 20 pounds, especially on these new drugs, so-called the GLP-1 drugs, which were initially started for diabetes. But those drugs have this effect of lowering the weight by 10 to 20 kilos, which is like 20, 30 pounds. And their blood pressure can normalize in addition to their diabetes being improved. And then we discussed other causes of secondary hypertension. Somebody's on high dose of Advil-like drugs for the arthritis. They can drop their blood pressure by 10, 20 millimeters. And then, of course, the secondary causes with decreased blood flow to the kidneys, that can be opened up. Somebody with a hormonal issue, whether they are producing too much of this hormone which increases the blood pressure, or too much cortisol being produced by a tumor. You remove those tumors, the blood pressure will come down. Mm-hmm. The next question I have is an easy one. Dr. Thomsen, I missed my dose. What should I do? Shall I skip should I double the dose next time, or should I take half the dose next time? What should I do?
So when I get that call, most of my patients already have what I call self-measured blood pressure skills. So I always ask them, what is your blood pressure now? When did you miss your last dose? For mild blood pressure patients, and they're doing well, we don't go back and take any extra pills. We just monitor them. But if they are on 2 or 3 medications and they miss that dose and their blood pressure is rising, we absolutely want them to take that extra dose. And in my office, we will call them back in 10 to 12 hours to make sure that they are doing okay. And you know what's interesting? Now that we have EMRs, I get a lot of portal messaging. So I will do a lot of portal messaging and double check my patients throughout the evening or early mornings as well.
Yeah, EMR is our electronic medical records, as you know, and we've gone on from paper charting to electronic health records. So, yeah, that's very insightful. The other question is, Doctor, can I try some over-the-counter herbal meds to help me with my blood pressure?
Wow. Okay. So just because it's herbal, it doesn't mean it's safe. And in fact, a lot of our prescriptions came from plants, right? So I really make it almost mandatory that I know everything that you're really taking, because it can have elements of leading to hypertension in it. It can be damaging to your kidney system. You have no idea, even though the word herbal is in your product, right? Your natural product. It can also maybe even cause weight gain. It can cause palpitations, so make your heart beat faster. So herbal doesn't necessarily mean it's safe. I'm very comfortable if you pass it by me, and again, I take advantage of the patient portal, so a lot of people upload those ingredients or the label to me, or they'll bring it in, bring the bottles in to me, and I have no qualms in reviewing it. And if I don't know, I look it up as well.
Yeah, in general, we respect herbs. I mean, they have been useful in the past, and there are some conditions where herbs help. But in general, we don't find any physicians treating high blood pressure with herbal medicines anymore. There used to be a medicine called reserpine, which came from a plant, but there are so many better medications available with better titration, better precision, that we don't recommend any herbal medicines. Yeah, that's all the questions we have. I hope we have addressed some of the common questions pertaining to hypertension. You can always reach out to Dr. Thomsen. She is in Glendora. You can always reach Dr. Thomsen at lthomsen@eminatehealth.org. I thank you for your valuable time. Until next time, thank you for joining us on this presentation.
If you like this video, please give it a thumbs up to help more people find this important health information. Click the subscribe button and the notification bell for access and reminders to more Emanate Health videos.